This video is presented by Subi, lecturer from Immanuel Arasar College of Pharmacy. Today I am going to teaching about diuretics. Introduction. A diuretic is defined as drug that increase the rate of urine formation. The primary action of most diuretics is the direct inhibition of sodium reabsorption. That means increased excretion at one or more of the four major sites along the nephron. An increased sodium excretion is accompanied by anion like chloride ion. Since sodium chloride is the major determinant of extracellular fluid volume, diuretics reduce extracellular fluid volume, decrease in edema by decreasing total body sodium chloride content. There are four major sites along the nephron that are responsible for reabsorption. They are proximal convoluted tubule, ascending loop of Henle, distal convoluted tubule, late distal tubule and collecting duct. Classification of diuretics. Site 1 diuretics. Carbonic anhydrase inhibitors. Examples are acetazolamide, methazolamide, dichlorophenamide, chloraminophenamide. Site 2 diuretics. Loop diuretics are high ceiling diuretics. Examples furosemide, bumetanide and ethacrynic acid. Site 3 diuretics. Thiazides. Examples are chlorothiazide, benzthiazide, hydrochlorothiazide, hydrobromothiazide, benzoflumethiazides. Site 4 diuretics, potassium sparing diuretics. Sodium channel inhibitors, they are triamterene amiloride. Aldosterone antagonist, example spironolactone. First we have see about Site 1 diuretics, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are derived from the sulfonamide antibacterials. The carbonic anhydrase inhibitors have an unsubstituted sulfonamyl group. That means SO2-NH2 group. Some Ca inhibitors have a heterocyclic ring and some have benzene ring attached to sulfonamyl group. Accordingly, carbonic anhydrase inhibitors have been divided into two groups. They are simple heterocyclic sulfonamide, metasulfonamyl benzene derivatives. Mechanism of action of carbonic anhydrase inhibitors drug. This class of diuretics inhibit carbonic anhydrase enzyme in the membrane and intracellularly in proximal tubules that causes the decreased reabsorption and increased excretion of sodium bicarbonates and potassium. Adverse effect: metabolic acidosis, hyperkalemia. Hyperkalemia means decreased potassium level, decreased glomerular filtration rate, hypersensitivity reactions. Uses: major use is in the treatment of glaucoma because it reduces the rate of formation of aqueous humor, thereby reducing the intraocular pressure. SAR means structural activity relationship. SAR involving simple heterocyclic sulfonamide. Acetazolamide is the most important compound of this group. The sulfonamyl group is essential for activity. The sulfonamyl nitrogen atom must be unsubstituted. Substitution of the methyl group on one of the ring nitrogen retains Ca inhibitory activity. Example, methazolamide. The moiety to which the sulfonamyl group is attached must possess aromatic character. SAR studies involving Metasulfonyl benzenes. The parent 1,3-disulfonyl benzene is inactive, but substituted analogs have diuretic activity. Maximum diuretic activity is observed when the position 4 is substituted with chlorine, bromine, CF3 or NO2. An unsubstituted sulfonyl moiety at position 3 is essential for activity. Replacement of the sulfonyl moiety at position 1 with an electrophilic group, example carboxylic group, result in decreased CA inhibitory activity. Side 2 diuretics. That means loop diuretics or high ceiling diuretics. Diuretics that produce peak diuresis than other diuretics and act distinctly on renal tubular function at loop of Henle are called loop diuretics or high ceiling diuretics. There are three major classes of loop diuretics. Organic mercurials, example chlormerodorine, Hg, mercaptomerine, mersalyl, etc. Sulfonamide derivatives such as furosemide and bumetanide, etc. Organic mercurials. The mercurial diuretics essentially contain Hg++ in an organic molecule. The organic mercurials have a number of serious limitations. When given orally, they cannot be relied on to elicit diuresis because of poor erratic absorption. After parenteral administration, there is a 1 or 2 hour lag in the onset of diuresis. Their ability to trigger a diuretic response depends on the acid-base status of the individual. They are ineffective when the urine is alkaline. They are cardiotoxic and nephrotoxic. Today's topic is over. Thank you.